ICUDDR regional webinar. I am the assistant coordinator for ICUDDR in Africa. And today we shall be looking at a topic, a very important topic, which is how to help families overcome members with substance use disorders. And we have very experienced speakers who are also the regional coordinators in 4 of the regions, sub-regions in Africa. And before I introduce the speakers, let me invite our regional coordinator, the ICUDDR Africa Regional Coordinator, in the person of Dr. Beatrice Kathungu, to welcome us to this webinar. Thank you for your patience, especially that we're starting a little behind the schedule. Thank you. Beatrice, over to you, please.
Thank you very much, Martin. Thank you very much, participants. It's always a pleasure to see every one of you coming to join us and collaborate. This is the Mental Health Awareness Month. We decided that we wanted to come together as a continent and do what is called peer capacity building so that we can grow together. And it was a short notice for all of you, and we appreciate that you have been able to join us. Thank you for your patience. We had a bit of technical challenges, but they have been resolved. And that's why we are all here. So it's very nice to see you. And thank you to our presenters. Thank you to our moderator. Thank you to ICDDR Kali, who is representing Kevin in this meeting. And I would like to ask her to say hello to you so that you can know her, because some of you haven't met her.
Good morning, everyone. I feel so fortunate, evening for many of you, to see so many here today, so many familiar names and faces. I'm Carly Searcy. I'm the Associate Director at ICUDDR for Programs and Membership. And today I'm very pleased to be here and to support this session. We are recording, and we will distribute the recording link after today's event. Thank you, Dr. Beatrice.
Thank you, Kali. We appreciate, and Kali has been actually assigned to work with us in the African continent. We have other people that are working with other regions, but she is our own. So thank you very much. We appreciate you, and we are glad to have you. Over to you, Martin. Thank you.
Thank you so much, Beatrice, and thank you, Kelly, for the purpose of political purpose. I'll be moderating this webinar. So once again, we welcome you. We shall be going straight to the presentation, and please, while the presentation will be going on, do not forget to use the chat box to ask your questions, and after the speakers would have made their presentations, we shall be taking your questions. So we have the first speaker, Dr. Rania Mamdouh. Dr. Rania is the North African Regional Coordinator for ICUDDR. And Rania will be speaking on codependency.
Excuse me, can you hear me with the mic?
Please go ahead.
Yes. Yeah, Dr. Rania Mamdouh. Rania, not Rania. I'm from Egypt, so I'm just trying to give a hint on the pronunciation of the Rania Mamdouh.
Okay, thank you so much. Maybe I will slow down on pronunciation, because so that I don't pronounce names wrongly. Thank you for drawing attention to that. Please, in case I pronounce your name wrongly, of course, we all do understand at times it could be a bit challenging because of some factors. You do bear with us. So go ahead, please.
Good evening, dear colleagues from all African region. How we get over, I'm sorry, this, I want to. How we help
Please go ahead, we
families.
can hear you.
Because from the all of those pictures, I don't see the slides. I want to cancel the pictures, our own pictures. Okay, from here.
We are seeing the slides,
how
Professor. I'm
to
seeing
help
your slides, Professor.
Thank you. How to help families get over their disorder caused by chemical dependency. Chemical dependency is a disease that affects the family system as a whole. It affects negatively the family function, the role and life of each family member. Families are so affected because the substance or alcohol-dependent patient will violate so many boundaries to get his or her substance of choice. Many physicians overlook family issues to their patients, and this is a big mistake in caring with patients with addiction disorder. Family members can have a significant impact not only on the process of enabling the addiction to progress, but also on recognizing the problem and in recovery journey. I will never forget one of my clients, the mother of a one substance use patient. She used to always tell me, there is an elephant in the house. Dr. Rania, there is an elephant in the house. The substance use disease begins small and gets bigger, bigger, bigger. All of the family priorities are declined. The whole focus is on the substance use member. How is he today? Is he sober? Is he high? Is he overdosed? Is he conscious? Is he unconscious? Did he steal the mobile of his brother 2 days ago? Did he take the money from my purse 1 day ago? We lose our own interest in our own needs, and the whole focus will be on the substance use patient, and that is why the addiction is a family disease. It's not that the family is merely reacting to drug abuse of an individual member, rather than the abuse has become a family condition that has inserted itself into every aspect of family life. Drug abuse problem has consequences for both the abuser and the family. Why is the family intervention is very important in the addiction treatment? Because 90% of actively addicted individuals live with their significant other. Because family attitudes is the risk factor of early experimentation and late addiction continuation. Because family is a risk factor for relapse. And because family orientation and recovery play a role in the relapse prevention. Not only the substance use individual has negative consequence, but the whole family also do see social deteriorations, financial deterioration, violence, accidents, psychological and physical illness. We all hear about one of the family member of a substance use patient suffering from spastic colon, stomach ulcers, migraine, hypertension, diabetes, depression, PTSD. If the substance use patient die from the substance use disease, grief and self-blame will be overwhelming the whole family. The intromission or induction of another member into the addiction process is one of the most famous consequences in the families. Maybe the families do certain adjustments to addiction, which could take the following forms: shift in their priorities, change in values, religious over-involvement, taking on the neglected responsibilities, like the parentified child. We usually see certain young daughters and young sons to take the responsibilities of the parents when this codependent family member is no more able to maintain his parental roles or responsibilities. We see a child taking decisions inside the family. We see a child being responsible of certain responsibilities of not of his age inside the family. We see certain children that become parents of their parents. becoming enablers, neglecting self-care, reduced or failed family communication. All of the above pathological maladjustments may reach the level of the handicapping codependency. So codependent behavior is the disease of the family of substance use patient. Codependency is defined as psychological condition or a relationship in which a person is controlled or manipulated by another who is affected with addiction to alcohol or substance. And in broader terms, it refers to the dependence on the needs or to control of another. It also often involves placing a lower priority on one's own needs while being excessively preoccupied with the needs of the others in the family. Codependency may occur in any type of relationship, including family, work, and also romantic relationships. Becoming harmfully over-involved with the addiction process in such a manner that enables the addicted patient to resist pressure to seek treatment and reduce the degree of functionality and well-being of the family member. Here are certain characters of the codependent people. We see them with an exaggerated sense of responsibility for the action of the others, a tendency to confuse love with pity, a tendency to do more than their share in any task, a tendency to become hurt when people don't recognize their efforts, an unhealthy dependence on relationship. The codependent will do anything to hold on to a relationship, to avoid the feeling of abandonment, an extreme need for approval and recognition, a sense of guilt when asserting themselves, a compelling need to control others, fear of being abandoned or alone, difficulty identifying feelings, rigidity, difficulty adjusting to change, problems with intimacy and boundaries, chronic anger, poor communication, and difficulty in decision-making. So simply, codependent member is responsible of the substance use member feelings. If the substance use member is okay, the codependent member is okay. If the substance use member is not satisfied, his needs are not fulfilled, he is not happy, so the codependent member is not okay and will be doing a tremendous effort to make the substance use patient happy. Another psychological theory called the dichotomy between the public-private personality, the public versus private dichotomy personality of the codependent. Normally, the authentic person is consistent and integrated between his public persona and private persona. But the codependent personality usually suffers that he is inconsistent between his public attitudes. His attitudes, values, and rules inside his society are so much discrepant and different between his values, rules, and attitudes inside his house and with his close family members. This is called the public-private dichotomy of the codependent personnel. So the codependent member usually circulates between three stages, three pictures. At first, when the substance user member is sober or claiming that he is sober, the enabler, the codependent member is enabler, is happy. He wants to support the substance use patient. So he allows certain things that should not be allowed. He allowed a late curfew. He allows long stay out of home. He makes for the patient excuses that should not be excused. He pays more rewards inappropriately. He pays money inappropriately for certain wishes for the patient. He bails out the addict. And when the codependent member, when he starts to suspect the substance use intake of our patient, he turns to be a persecutor. Stir up the pot in order to put the addict on the defense and look for a way out of the pain. He starts to shout, scream, guiltifying the patient. And when the substance use problem is overwhelming and more, and our patient is more indulged into drug, our codependent member will be victimizing himself or herself, seeing himself or herself abused, picked up, insulted, not recognized with his good qualities, and all the good things he or she doing for the family and not recognized by this substance use member. This is a little test we are providing inside our family intervention to the families, and we invite them to explore each one, how we can be codependent, or how every one of them has the tendency to be codependent with his family member with substance use problem. One of the big famous manifestations of codependency is denial, which is a defense mechanism used unconsciously to minimize the problem or its possible consequences. It can be protective in that it protects from experiencing too much pain at once. It becomes harmful when it is maintained and used as one's primary way of coping with the problem. Next codependent problem is enabling, which includes any type of behavior that makes it easier for the chemically dependent patient to continue to use drugs or alcohol. The family's intention is to help, but instead, the substance use patient is shielded from the consequences of his addiction, doing for some things that they could and should be doing by themselves. Simply enabling creates an atmosphere in which the substance use patient can comfortably continue his unacceptable behavior. I had a movie, one of the most famous movie for, Julia Roberts. This movie is called Ben is Back. Julia Roberts was playing the codependent personality as in the book. She is a mother of Ben. Ben was in a treatment program, and in the Christmas Eve, Ben decided to leave his treatment program without a permission of the parent, and he suddenly appeared in the house without telling anyone. And for the next 24 hours of this movie, all the disasters of any substance use problem arose, only because of the codependent family member mother who accepted and gave excuses and enabled of things that she was not have to do.
Mama, is it you? That's it.
See here, instead of telling him, why are you here? Why did you leave your treatment setting without telling anyone? She hugged him. She was happy.
Did you see? He's gained some weight and he's got the sparkle back in his eyes. He's clearly
See, she gives him excuses. He's now in good weight. He's in good shape. He deserves to be with us in Christmas Eve.
better. Yeah, then why are you hiding everything?
We said we weren't.
See here the parentified child? Her younger daughter is telling her, okay, mommy, I hid all the medicines of the house.
Remember?
Hey, Rudy, weren't Christmas. You get a day. This time.
See here, she tries to convince her husband, who was totally refusing that his son is back against their wishes. And she was giving the son excuses. It's Christmas, let's give him a try.
You are back in sober living.
Yeah, okay.
You do not leave my sight ever. Because for the next 24 hours, you are mine, all mine. Got it?
I got it. It burns.
And another enabling, she agreed that he stays with them for another 48 hours in one condition, that he should be with her all the time. And see what happened. They decided to make shopping in the mall, and let's see what happened in the mall.
I thought you were dead.
I put my family in danger.
This is on you.
He met the old guys with drugs in the mall. They took his phone number, and he went night to buy drugs for them. And he tried to convince his mother that I have to go to those guys because I owe them money. If I don't pay them the money, they will kill me. So what she did that.
If I don't deal with this, then it could be worse next time.
Okay. You go in, pay the man, and get right back out.
Lock the door.
She went with him to the drug dealer so he can pay for him the money of the last time, but he was lying. He bought drugs.
You need to go home. If you really knew me, you'd be done with me.
I know you.
No,
I know.
you don't, Mom. You don't know me.
Unlock the door, Ben, right now.
I told you not to believe me and you didn't listen.
She knew that he used to take, he is beginning to take drugs in his room, and she started to knock the room aggressively, as you see. Then she started to be the persecutor, aggressive, nervous, and how she was screaming, let's see.
All I need is for you to do me just one move there.
I'm looking for my son. I can tell there's something wrong.
You need to come home.
Not without it.
And now he disappeared. He went back to the drug dealers and accepted to deal with drugs to have his own amount of drugs. And he disappeared. And she spent the whole night searching for him in the Christmas Eve.
The things that I've done to myself and others.
You can't save them.
I will save for you the end because the movie is very touching and we should all see if you need my opinion. Enabling includes taking over the responsibilities of the addict. And also the codependent member do have very distorted boundaries between this codependent member and the substance use patient. There is often over-control, not allowing each person to be responsible for his or her own actions, and lots of criticism. There is another small test, simple test, we provide during the family intervention to let the family explore how they can be enabler. And take care, my colleagues. Counselors can also become enabler without noticing during the treatment process. Codependent members do have unhealthy rules. Don't talk, don't feel, don't trust. Don't talk about your brother using drugs out of the family. We cannot feel happy without the patient. We cannot go out without the patient. We cannot have fun without the patient. We cannot travel without the patient. We can't trust anyone. We only trust our head that we can rescue him. And this is all denial. Impaired communication. Communication between family members become minimal along the process of addiction and finally becomes distorted and governed by dishonesty, guardedness, indirectness, and abusiveness. Instead of the healthy communication, openness, honest. Conversation lose their positive components and focus almost exclusively on the negative. Codependents tend to make you statement instead of I statement. They stop letting the other person know that they understand how they feel. Finally, they stop sharing responsibilities for their life together and focus on trying to assign blame. Toxic shame. The codependent member usually start to say, I am a bad person. I am a bad parent. I am responsible of my son's substance use. I did something wrong in raising my son. This internalized toxic shame usually takes two ways: the shameful thoughts, attitude, and behavior, and the shameless thoughts, making ourselves superhuman. This substance use problem can never happen in my family. We are coming from previous generations that did not indulge into substance use before. We will be we will be solving our problems and start to act as a shameless. Self-loss, when the focus shifts mostly from oneself to the addict and others' painful feelings, irrational beliefs, controlling and enabling behaviors are created. These behaviors overwhelm and cover up larger aspects of the healthy life. The healthy self diminishes, becomes lost, and the unhealthy self grows, resulting in enabling the addiction more and more. So codependency, it's a sort of over caretaking in order to meet the need of feeling loved, accepted, or productive. The codependent member is always a victim. He's not mastering his feelings or life. His feelings and his life or her life are mastered by the substance use and by the disease. As a final result, one's personal identity becomes lost. So, is there any good news about this codependent family member? Yes. Living with an addicted person is not easy, but most children are resilient. Having a substance use family member does not mean that the other family members will be diseased. No. This means that they can overcome these difficult circumstances and become strong, healthy adults. They build on their own and other strengths. And for those who may have resulting problems, help is available. So we really highlight for the families that help is available. So any recovery treatment program for a substance use patient should have a very important component of a family intervention. And these are some of the evidence-based family intervention, and we invite the families to use one of them. Thank you so much, my colleagues, and I appreciate that Martin takes the talk again. Thank you so much.
Thank you so much, Doctor, for that insightful presentation on codependency. We move straight to the next subtopic, which is disturbed family roles. Disturbed family roles. And to take this is Dr. Morekwe. Dr. Morekwe, please, over to you.
Thank you, Martin. Let me just share my screen. Window. Where's my... Just give me a minute. Can you just kindly share on...
Okay, share from here, right?
Yeah.
Okay, thank you.
Okay.
Please confirm if you can see the screen.
Yes, we can. Let me also just take this opportunity to thank Prof. Rania for the presentation, and I want to believe there's a synergy that I got when she presented about codependency. So we'll move right along to talk about, let me just show my face for a minute and then I will switch off the camera. So we'll talk about disturbed family roles, which she has touched on a little bit as she was presenting. So I want to buttress what she mentioned about family. Most importantly, the fact that addiction does, in its definition, touches on family, that it's a relapsing and chronic family disease. What is also important is to highlight this definition that I believe actually stems from Maury Bowen's family systems theory, which outlines family as a group of two or more people with close and enduring emotional ties. It's actually important for us as clinicians and as scholars that are here today to actually ponder on this definition, especially within the African context, given the different dynamics that actually exists in our countries. A lot of times when we think about family, we think about blood-related family, and the issue of non-blood related family is not something that sometimes, I don't know, that we think of when we think about family of the person with SUD. So in terms of family, as a clinician, it is important that we have to have this definition, especially when we have a patient. I don't know how many people are clinicians. When we have a client who we are seeing, to always ask who is important to you, whose family, because it might not necessarily be somebody that is blood related. And it speaks a lot in terms of the role of addiction and as well as treatment. We've already heard from Dr. Rania speaking a lot to the last bullet, which talks to the fact that family plays a role in addiction, and it also plays a role, especially when it's a functional family, in terms of treatment. There are different types of families, as quoted by Jerebic 2019. Dr. Rania already spoke a lot about functional families, so I'm going to go into what is described as cultic family. It's flooded by toxic affect of shame, which she has already noted. Problems are normally ignored within cultic family. It's more like a cult. There is rigidity in terms of what happens in the family, and things are not really taken out of the family. Family is always considered to be more important compared to individual needs. So usually somebody that has the things going on, their needs are minimized as compared to looking as a family unit. There's a lot of manipulation within this family structure, and hard work and sacrifice is more glamorized in a cultic family. So a lot of secrets are kept within a cultic family structure. And then we have the permissive family structure. Compared to the cultic family structure, permissive family structures usually are unstable in nature. They ignore pain and problems. There's lack of emotional boundaries, lack of boundaries within the roles and responsibility. Everything goes in terms of a permissive family structure. And roles are often interchanged. I think Prof. Rania talked about a parentified child. So you would find that within a permissive family structure. And then the corrupt family structure is characterized by lack of boundaries, similar to the permissive family. Children, unfortunately, in the corrupt family are often bearers of parental destruction and shame. There's a lot of criminal activities within corrupt families. One could ask, why do we really bother in understanding the types of families that we actually deal with as clinicians and as researchers? It's quite important because it helps us in terms of understanding the interventions that would be appropriate for the client and the family. I think I'm going to just quickly go through. I'm seeing Martin is just reminding me that I did need to be mindful of time. But when we talk about a functional family, usually there's clear roles and responsibilities. Boundaries are very clear. There's the systems are just as I've already noted, that family is seen as a system. So within a functional family, the systems are just and are flexible to cater for everybody's needs. Our strengths and limitations are acknowledged, as well as the parents within functional families. They do acknowledge where they have limitations. Usually it's also characterized by family connection. As compared to the dysfunctional family, which I believe has been said a lot, lack of boundaries, distorted expression of affection. And I think, Prof. Rania, the movie that you showed, the clip, clearly demonstrates that there are no clear roles and responsibilities and very distorted relationships, very unstable in terms of how they function. So we can then think about what are these disturbed roles that we are talking about. We can go to the next slide. We can go to the next slide, Martin. There has been a lot of documentation and research about family roles within addiction. We have the hero, the mascot. I think, Prof, you talked a lot about the enabler, the lost child, and the scapegoat. Let's begin and see within a family, who is considered to be a hero. And I want to highlight that, you see, family roles or disturbed family roles, people do not necessarily consciously choose them. These are processes that happen unconsciously. And as you'll see in the next slide, usually they do resemble things that are going on within an individual who is actually within that role. So we can go to the next slide, Martin. Prof. Martin. Yes. So a hero, or somebody who takes the role of a hero, I looked at it that they do have strengths, but as I've already mentioned, there are challenges of actually being in this role. Usually they portray a very self-driven and very disciplined demeanor. They are usually within families the person who overachieves, very goal-oriented, more likely to be successful, very organized, and they do take leadership skills. So within a family, it's somebody that would always make sure that things in the family are going well. If ever it's a student, they're doing quite well. This is the type of person within a family where we are always praising him for all the success that they are achieving. And unfortunately, for the hero, the need for perfection drives them to ignore problems that exist within the family. They are very uptight and not relaxed because of the need for perfection. They have a sense of shame and guilt, and then overcompensates that by actually being very organized and being very successful. They normally have a need to control, I've already said that, and they have a fear for failure. So this is quite important when you are a clinician to understand, especially when you are doing family therapy, to understand and be able to identify who within the family is a hero. And we are saying it's a hero because of the strengths that I've noted here, or the positives maybe that come with it. But we have to be reminded that even as we see him as a hero, there's a need to deal with their own issues because of the impact of addiction within the family. We can go to the next slide. We can go to the next slide. I don't know. Okay. And then we have what is called the mascot. The mascot is somebody who usually passes jokes. He is considered, or she is considered the jokester of the family. Other people would say sometimes they bring the family together, especially when there are sad moments. They're the ones who usually would jump up to ensure that it's fun within the family. In terms of the clinical issues that one might look at is the inappropriate behaviors that they mostly exhibit because of their need to make sure that things are more stable within their family, so they will make jokes. Inappropriate behavior, immature behavior, whether it's a child or even an adult. And the mascot usually has their needs unmet, and they they mask this by a sense of humor. They laugh things off. And even when serious conversations are going on, they would actually try to diffuse the seriousness with humor. There are poor decision makers. They tend to always seek attention, especially when things are uncomfortable with the seriousness of addressing issues of addiction. They have underlying feelings of embarrassment, and one would see the link in terms of using a sense of humor to actually address feelings of embarrassment. I think, like the enabler, Prof. Rania, you have actually done a lot in terms of explaining what an enabler is. An enabler is somebody who presents as if everything is okay. They will make sure, as already said by Prof, that they would speak on behalf of somebody with substance use disorder. They would protect the person. And this, I always say that if you're a clinician, it's not that they would want somebody to continue in addiction. It's just that they have feelings of inadequacy and helplessness, and therefore it presents itself as trying to remedy the situation and ensuring that everything in the home is okay. I think that Dr. Rania did mention that they will give them money on the side. They will make sure that they go out of their way to make them feel as if they are comfortable, or somebody with SUD, to make them feel comfortable. And as a clinician, it's something to pay attention to address the feelings of inadequacy as compared to actually just be looking at what they do. We can go to the next slide. I know my time is up. Can go to the next slide. The next slide is the lost child. The lost child might be a child, but it can also be an adult. This is a role. This person is often quiet within the family. They at times might be forgotten that they actually are present because they are invincible. They avoid attention, and they present as if there's no problem. When it comes to children, they may even escape into their own reality, even as adults, because I've seen that as a clinician, that this person lives as if they're not part of the family. And then the challenges with the lost child, because of their being isolated, usually their needs are not met. People tend to forget and focus on their needs, because the focus now is on either the mascot or the person with the SUD. They normally do not feel emotionally connected to family members. And what is seen with the lost child is that they have feelings of shame and inferiority, and they never really get into conversations about SUD or addiction within the family. And then the last role. The last role is the scapegoat. The scapegoat's role, the person normally draws attention from the problem by actually being very self-destructive. They're not like the mascot. Their behavior of being defiant and being self-destructive actually draws attention from the problem, which is addiction or SUD, right? They are defiant. I've already said that. They usually present as irresponsible within the family structure. The scapegoat normally exhibits inappropriate emotional expressions within the family, so they are more likely to have anger outbursts, where people would feel that it's inappropriate. The scapegoat within a family structure is somebody who is normally seen as the black sheep of the family. So in terms of addressing issues of addiction within the family structure, it's important that we understand when we say that addiction is a family disease. What is it, or how is it a family disease? It's a family disease because you can see, as I've already outlined, that the roles that unconsciously people actually take on. as a way of actually dealing with addiction themselves. It's quite important because I know that even the previous speaker talked about family interventions, but I know that my colleague will go deeper into talking about family interventions. These interventions are informed by our understanding of the roles that family members actually take on as a way of coping with issues of addiction. Okay, I've tried to keep my time. So I'm hoping that as we continue the dialogue with my colleagues, we'll get to see how we can actually help our families within our countries to deal with issues of addiction. Thank you.
Thank you so much, Morekwe, for that presentation. Very educative. Participants will agree with me, or rather, the attendees will agree with me that it was a wonderful presentation with so much to learn from the presentation. So we move straight to the next speaker who will be speaking on family assessments, and this will be taken by Dr. Donald Okoye. I understand his presentation has been shared, so just give me a few minutes. Let me pull out his presentation from the main boss. Dr. Okoye, can you hear me?
Yes, Professor.
Okay, good. So I want to believe you're prepared for your presentation. So just give me a few minutes to pull out your slides. While we are sorting that out, please, you can also seize this opportunity to send your questions so that we can put the questions together ahead of the Q&A session. Thank you. Rob, confirm if this is your presentation.
Sorry, Martin, that is the last presenter's presentation.
I think Samuel, you can share because you have it. Just share, Samuel.
Okay, I may not be sure if I can do his own, but let me try. But Martin, please go ahead, try from your end. But let me try. It's a major disaster. This is a major disaster. This is a major disaster. Rana.
It's okay, Samuel. We'll get there.
Oh, pardon me.
As we wait for the presentation to be picked up by either Samuel or Martin, I would like to give a question to please ask.
Prof, I think I've been able to pull out your presentation, right? Please confirm.
Good. Thank you.
Oh, yes. Thank you for this presentation. I think this is the first. You can move to the next page. So generally, this is a background about family assessment. And one of the things is it can only be done by a practitioner, a competent practitioner. Apparently, this topic I'm discussing is one where personal opinion is restricted because it's much more of psychometrics. And the process of assessment requires empathic, non-judgmental approach. The process can take several sessions. It's not something you can do in one day. And the presenting history, the first contact history is very important in laying the foundation for subsequent follow-ups and sessions. You may also get patients and clients presenting in a crisis. And when you do these sessions, you need to be very brief because if these patients get exhausted during interview, you may be as good as having lost them. They may lose interest once and for all. It's one of the reasons why sessions may be many. Detailed and quality information collection is valuable if we are to serve these patients and the families. And usually it's advisable to involve a family member or a caretaker for sustainable treatment. It requires teamwork. It's not an individual effort, and a guided approach. So common assessment approach is valuable. Common in the sense that we need to put our minds together as a team and think in one direction and make common decisions for the patients. And of course, assessment is followed by treatment. Next. Next. Yeah, so for the approach, you normally prioritize, forget about that era A, forget about it. You need to start with the treatment of emergency cases or patients and clients in crisis and acute problems. They take priority. And when you are dealing with them, you have to establish and confirm that truly speaking, they are using psychoactive substances. And of course, history, information, and records is part of the backup information you need to confirm that this is a patient needing help. There has to be physical and mental state examinations, and of course, testing for substances, and you access clinical records where applicable. And any relevant additional information and leads that can help you to manage these patients. Next page. So you've got to determine the extent of dependence by identifying the types of psychoactive substances in use, the frequency, the patterns of use, routes of administration, determine sources of substances, Determine evidence of harmful and hazardous use of substances. And alcohol, if it's alcohol, the types of alcohol used, and determine whether the patient is in withdrawal symptoms or not. This can be a crisis for the patient, and you're unlikely to get attention of the patient if you do not cool down the withdrawal symptoms. And of course, you also determine the extent of risks of the substance abuse for the patient or client. Next page. So there are physical and mental health problems associated with the chemical dependence, and you need to determine the current and or previous physical complications associated with the use. If there are infections with blood-borne viruses or other conditions, if the patient and or client is continuing with related risk behaviors, look at also the emergencies involved in substance use, particularly with regard to injecting drug use, and look at the damage to the liver, abscesses due to injections, and overdoses as emergencies to be dealt with very urgently. Of course, they are in enduring and severe physical disabilities at times, so this has to be examined. And if so, they also need physical attention, physical health attention. They may have sexual health problems also. And as you may know, these people are not accessible. They are not adequately accessible to healthcare because of criminalization. And this takes me back to Professor Rania's video demonstrating the need for us to love and to be empathic to these people. Related sexual health problems are pregnancy-related risks. Right now, I actually have a patient on multiple substance use and is pregnant, and another one who is a trafficker and user that needs treatment. Look at the current and or previous psychological problems the patient might have gone through. Consider personality problems and disorders with regard to chemical dependence. Determine if there are incidences of self-harm. Look at the history of abuse and or trauma and psychiatric disorders and severe psychiatric comorbidity. Next. So there are social problems they go through and the risk behaviors once more. So you need to identify how these people are housed, if they're employed or not, if they are victims of domestic violence or they meet domestic violence to other people, and the offenses they commit. These factors determine the future progress of recovery of the patient. And of course, for those who are injecting drug use, those on IDU, they have higher risks because of likelihood of being infected with conditions like hepatitis, syphilis, HIV, AIDS. And of course, you know, their behavior, which includes flushing, sharing blood with those who have used substances to deal with the withdrawal symptoms or inaccessibility. Risk factors have also to do with the access by children. I think we all know that access is very crucial to control of substance use and the risks of harm to the young persons, and then success of treatment and the desire to change with regard to the patients and the clients. So all these are aspects that are necessary when we are conducting assessment. So we are likely to have adults and children. If these are adults, then we get their consents. And if these are children, we get assents, which means we definitely need people who live or care for these people. And special circumstances in emancipated children, that is children who, like those who have delivered their pregnant and all those kind of things. And then special attention to children of substance using parents. There is need for secure practice or use by the parents themselves, because we all know the moment parents expose their children to use of drugs as their practice, it's likely that the children will easily access, and that is the start of the chemical dependence. So there should be restriction. There should be privacy and restriction if the parents have to use. And then you need to determine the level of responsibility of the parents as a way of protecting these children. And of course, if they are using particularly injecting drug use, whether they are accessible to syringe exchange program or not. And if they have to use the syringe, if they have to go on this program, then the element of sterility must be observed to avoid infections. It's therefore necessary that these people are accessible to testing for infections. Those infections are mentioned among others, and access to vaccination, because we know hepatitis can be prevented through vaccination, and access to expertise to manage the patients and the clans. And of course, the mechanism for the team spirit and referrals. If this is at lower levels, how do we get these patients and clients to get treatment or to reach treatment centers where need be? And of course, there should always be a monitoring and evaluation framework for this kind of program as a way of auditing our work and what should be obtained. So if a patient is in current use of the substances, history is crucial. You need a history of types of drugs used, quantity, frequency, pattern, routes of administration, symptoms of dependence, sources of the drugs, if they are prescribed medications, tobacco, alcohol, including quantity, frequency, and pattern, and the symptoms. Next. So having said that, and expecting that, expecting that we have done this as we have said, we then go to next. Yes, we move to the screening, assessment, and monitoring tools. There are very many tools available. I just chose a few, and I would like to inform the audience that I have shared references to this presentation, about 11 references, which can be useful. Some references are dealing with these tools. So the essence of this is to standardize the practice and patient management and treatment so as to determine the risk and dependence. So the first one is audit, should be audit C, basically for alcohol use. And the second one is CAGE, it's also It's also for alcohol. And the third one is severity of alcohol dependence questionnaire. As you can see, the first three are all about alcohol, and I deliberately made it so because we know that alcohol is one of the most widespreadly available, easily used, and extensively affecting families and health of people. The fourth is the Clinical Institute Withdrawal Assessment. This is for the withdrawal symptoms of alcohol. Again, now the fourth one on alcohol. Now the fifth one is on opiates, withdrawal symptoms, the clinical opiate withdrawal scale, or the short opiate withdrawal scale. As I said, all these, most of them, I think I have brought forward the citations that you can read and broaden your knowledge. Then tweak is to screen for alcohol in pregnancy, and then a Clinical Institute withdrawal assessment for alcohol. It's also for pregnancy. And of course, we may need to screen for mental disorders in these patients. So we use mental health screening form and BEC for depression and anxiety as very common illnesses. And tip 50, not percent, tip 50 manual, it addresses suicide and parasuicide. So when you look at this, it's not easy to get just one tool that will address everything, but depending on what you find, particularly from the history and the examination, it will give you guidance. And for purposes of assessing the family, I have just chosen three. The stress-strain coping support model, aimed at reducing the strain and stress that the caretakers and families go through when they are caring for chemical dependence cases. Reinforcement approach and family training, craft intervention. This is it's used to train the families to develop coping skills when they are dealing with the chemical dependence in the family. And the third is alcohol behavior couple therapy, targeting couples who are affected, particularly with regard to children. And as you know, we may have children who are very young, and we may also have children who are very old adults, but they are still children to the parents. And obviously, the families need psychoeducation, support, and coping skills. Next. Next slide. Yes, so we go to testing. So what do? Testing requires very good competence to handle samples, to read the results, and it should be done in accredited laboratories. No negotiation on that. And of course, screening tests in this case are used as a first line because they are quick, cheap, and easy. And of course, they are mainly immunoassays and dipsticks. Once you do screening tests, you may need to do confirmatory tests. And these ones use gas or liquid chromatography and mass spectrometry. They are slower, more expensive. Drugs and their metabolites are detected, and they are gold standards for testing, like those who use drugs in athletics. Urine is a very common sample we use. It shows drugs. It is less invasive, not Bob invasive, less invasive, cheap, and relatively fast. But there is also risk of urine being adulterated because someone wants to hide the status. Another person can dilute the urine to conceal. and even the urine may be substituted altogether with another person's urine or something else. Next. Yeah, these are continuation. We also have oral fluid tests. These are recent, they're easy to carry out, and the detection is in 24 to 48 hours, but they are very easy to adulterate. And now this is why the laboratory where testing should be done must be accredited and must be handled by competent persons. We can also use hair to test for substance use. They're sensitive because you can detect substances after many more months, unlike the urine and others, which may not last long. They are less sensitive, but uncomplicated to use. Hence, their use is limited. Next page. So here are some of the durations, the period taken when we test for these substances, how long it takes to get results. We have the first row, benzodiazepines. Then we have cocaine metabolites. We have buprenorphine. We have amphetamines and methylamphetamines. And I know Professor Moreko, you know, South Africa is leading in amphetamines and methylamphetamines in the world. We have methadone. We have codeine and hydrocodone. We have heroin as detected as a metabolite of morphine. And as you can see, morphine is in the 48-hour category. Then the cannabinoids, if they are cannabinoids, single use 3 to 4 days. Cannabinoids 3 to 4 days, single use 5 to 6, moderate 20 days. That is within that period, you would be able to detect the substances used in urine. Next. Assessment of risk is very crucial and one of the greatest purpose of assessing. So you carry out to look for overdose risk, polydrug and alcohol misuse, and safe injecting practices like sharing needles, and safe sexual practices when people are in a subculture because they have detached themselves and they are few. So they can even have multiple sexual partners and partners within the group, the risks of self-harm and harm to others, and the risks of dependent children. You've got to determine the ages and levels of contact, substance use in the parents' functioning, drug-seeking behavior, that is supervised. If that's the children, if they're unsupervised, then they definitely will develop drug-seeking behavior. Or if they deal with unsuitable characters like house helps. I think we are all adults and we have seen our children demonstrate what they learn from house helps and unsuitable characters. Drug funding and diversion of family income. Those are risks. Parents' physical, mental health functioning of the child. Emotional support of parents from us, routine, such as getting to school on time. Support of networks for the family, from families, friends, and relatives, and professionals. And safe storage of drugs and paraphernalia. These are all important when we are looking at. So we then come to social functioning again as an area to look at. You look at the partners of the patient, clients, the family, and support, and see how the patient or a client is functioning socially. and look at the housing, education, employment, domestic violence. All these, they strongly influence the recovery of the patients and the functioning of the family. At some stage, there is involvement with criminal activities and offenses. As you know, the UNODC is actually a United Nations Office on Drugs and Crimes. These two things are related. So you need to investigate if the patient or client has been arrested before, convicted, is on warrant of arrest, or is already charged in a court of law. And at the back of your mind, always remember, these people enjoy human rights and they need our protection. You investigate for probation or attachment, whether he has been jailed or not, history of violence and disorderliness that may culminate in criminal activities or offenses against law. If he has been fined or bonded, a little bit, not back. Previous page. Okay, so we can go to physical and psychological health. Again, this one requires detailed history taking, look at presenting symptoms and perceptions during the session, past medical history, psychiatric history, and current symptoms, complications, accidental or deliberate overdose, current past infections, all these. I think these are standard. Next. Yes, yeah, these people have to be examined. As a professional, you have to examine the patients and look at the general health to get an overview of the state of the patient, conduct an intake form or mental status examination, inspect for injection sites for injecting drug use, including genitalia, limbs, groin, cubitus. Assess the weight and height of the patient, urine testing for diabetes and infections, and blood pressure. Next. So these people have to be investigated, as I said, for hepatitis, HIV, AIDS, and syphilis, pregnancy tests, and tests for bodily functioning. Systems, CVS is cardiovascular, respiratory, gastrointestinal, musculoskeletal, all the systems have to be examined and look at the diet and nutrition of the patient with the aim of giving advice. So these are the references that you can look at when you have free time to strengthen the presentation. Thank you very much for listening to me.
Thank you so much, Professor Donald Kokoya, for that another insightful presentation. Attendees, you will agree with me that each of the presentation is, if we take it as a single presentation, you know, without having to combine the presentations, you will agree with me that it suffices for a webinar. So you please bear with us, and we appreciate the fact that you have been very patient with us. We still have one speaker, but before I call on the speaker, let me call on Beatrice to note something before we proceed. Thank you. Beatrice, are you there?
Yes, thank you very much. And thank you, Dr. Kokonya. And like Dr. Kokonya said, the area of assessment cut across psychiatric assessment, it cuts across SUD assessment, and it also does cut across psychological assessment. And therefore, I would like to make a little presentation about the psychological assessment part of it to just, you know, strengthen or complement what Dr. Kokonya has presented, that has given us very beautiful insights on, you know, assessment when we have clients with SUD and their families. I hope you can see my slide, Martin.
Yes, we can see your slide.
Can you?
Yes, yes, please.
Very well, thank you. Yeah, thank you. So, like Dr. Kokonya has said, we want to understand the entire family in perspective, and so that we are not only helping the client, but we're also helping the family. Remember, Dr. Rania and Dr. Murekwe did indicate that when you have an SUD in a member of the family is actually sick. So we want to also assess the family itself. And there are a couple of tools that are used largely with one common goal: to give us insights into the family system. Remember, the family is a system. And why it is important to assess the family is that by assessing the family as a unit, we get the family strengths, we get the family challenges, we understand the unique dynamics in the family. We're able to know, where did we begin? When we began with this client, where was the family? And track how they're progressing over time. And as we are thinking that we are discharging the client, where is the family at that point? The other thing is that the process of assessing the family in and of itself becomes therapeutic, because it does give a chance to the family members to reflect on their own issues as a family. Remember, when they bring you the client, they are thinking the client is a problem. So as you assess them using some of these tools, they too begin to reflect on their own relationship patterns, their own challenges, and that gives them insight and self-awareness and motivation to be part of the therapeutic process. Now, just a little or a few examples of some of the tools we can use. We can use family questionnaires, which are basically tailored to gathering information about the members' own perceptions of their functioning as a family, of areas like communication styles, how do they problem solve, how do they express their emotions, overall, how are they satisfied with their family? So this is a structured way that members can express their thoughts, their feelings, and in so doing, the therapist is able to check areas of strength as well as areas that require intervention because of dysfunction. The other one is called the family life cycle assessment, which is anchored on the family life cycle development theory. Now, that theory basically has got stages through which a family goes through, beginning with the stage where the young adult leaves home. Then they go out and establish their own relationship, intimate relationship as a young adult. Then they start, they get married. Then they are families with young children. And then the children become adolescents and they are struggling with the issues of raising teenagers and also having their elderly parents. Then the stage where the family begins, the children are grown up and they're launching them into the world and the whole empty nest space. And each of these stages can actually be a predisposing stage for substance use in its members. For example, when the young adult wants to leave home, they are not confident about leaving home. The parents have a problem of wanting to keep them because they feel that they are able to take care of them better. That can be an issue that can predispose people to substance use. When the empty nest stage comes and the children have all gone, the family members could end up getting into substances to cope with the loneliness. So by doing family life assessment, the therapist is able to understand how is the family dealing with each of the tasks, the developmental task of each stage. Are there some challenges? How can they help them navigate these challenges so that the risk for substance use is reduced? The other one is what we are calling the structural family assessment, really anchored on the structural family theory, which focuses on the structural organization of families, including things like boundaries. For example, what is the parental boundary, the spousal boundary, the siblings boundary? Sometimes over time, the boundaries have become so enmeshed. The children became enmeshed with parents, maybe because a parent, one of them was a person with SUD, the child took up the role. I think Rania talked about the parentified child, sometimes a triangulated child who gets into the parent system and becomes like a co-parent. Now, sometimes it's the roles. You heard about the super child or the hero. Her roles, she's taken up the roles of what would have been a parent. So you end up finding that there is dysfunction in the structure of that family. Sometimes it's the hierarchy. Maybe the father was a person with SUD and the mother took up the role, or a child as the head of that family. So this process looks at those dysfunctions and works towards identifying areas that will require to be improved and to be readjusted in the family structure. And finally, we have got the genogram. The genogram, I think, like the name suggests, it's a visual representation of family relationships and dynamics across 3 generations. It's based on the Bowen theory, which says that the problems of families go beyond the current generation to past generations. So it uses symbols and patterns to depict relationships between members in different generations and also key events. The idea is to get deeper insight of the family's emotional connections, the patterns of behavior, the influences, and this can help the therapist identify problems or areas of concern across generations that may influence the history of this family and the history of this specific client that you will be dealing with. So that's just a small wrap up about the area of assessment to complement what Dr. Kokonya brought up from the psychiatric perspective, which will then lay the foundation for the interventions that Dr. Moses will be talking about. Thank you very much. Over to you, Martin.
Thank you so much, Beatrice, for adding to that earlier presentation. I think we have also benefited from this addition. We appreciate that. So we'll go straight to the last speaker, that is Professor Moses Mamdouh, and he will be speaking on family interventions. Professor Mamdouh, are you there? Okay, good. I can see you. Are you sharing from your end, or I share from my end?
Please share from your end.
Okay, thank you, Prof.
Yeah. All right. Good evening, everyone. Sorry, my main network has not cooperated with me today, so I have to be using my small phone to do this presentation. That's why I asked Dr. Martin to help me share. I hope you can all hear me.
Yes, we can hear you very well.
Yes, you are
Okay.
audible.
Thank you.
Thank you very much. Okay. Yes, all the previous 3 speakers have made the work very, very easy for me. And in fact, I don't really know what to say, because what I had to say was just a summary, because by the schedule, I'm supposed to speak for about 15 minutes. So I just came with an overview of what family intervention is all about. Please, let's go here. And we know that there are different types of family, and this have been enumerated by previous speakers, and the family is the primary agent of socialization. We have had that. And no client or no substance user exists in a vacuum. The family is an element of the micro environment that interacts with the macro environment, and personal characteristics, in the etiology of substance leading to substance use. So we cannot treat or manage a client, in isolation, because it doesn't exist in a vacuum. So we have to treat or manage people who use drugs in the context of the environment, particularly the family. And we know that the family upbringing, family system, and family dynamics generally, contributes to substance use. There are different types of family interventions, but most of them are used actually more effectively in the preventive aspect of substance use, because when one intervenes early, you'll be able to prevent or delay the use of substances, and they are more effective. So most of the evidence-based approaches actually are used in prevention, and there are some evidence-based family interventions that have been mentioned, and some of that are listed in the UNODC, evidence-based intervention programs. SAMHSA has, and even the European Union also have theirs. We have home visitation programs, e.g. the Nurse Family Partnership for young mothers who have no experience of rearing children and being mothers for the first time. So this helps them. And then we have a behavioral parent training, and where we think that there's some faulty parenting, and some interventions involve family skills training, where we think that the the parents, don't really have these skills to bring up their children, and the children do have acquired some, maladaptive behaviors, and all have to be trained on how to conduct themselves, how to live with one another, how to communicate with one another. And once they acquire the appropriate skills, then this is able to limit the use of substances or prevent or delay the use of substances. And we have intensive family interventions, e.g. the family therapy. And this is the one that you can use not only in prevention, but use it for those who have started using substances or who have developed some deviant behaviors or have gone very violent and already using substances. So one can use that, particularly in children and adolescents, to, as I said earlier on, to prevent the initiation of drug use or to limit the use of substance use, and so that complications, are prevented. Otherwise, the client might, graduate into dependency, and that's what most of the interventions are trying to prevent, so that people who have not used substances can be prevented from using substances, or if they have started, if they want to use, there's a delay, so they don't start early. Because once they start early, then they can develop dependence very easily, by a phenomenon called telescoping. So we try to delay it. And if they are using, then we try to see how we can help them out so that they don't become dependent on the substances that they're using. But there are general principles of family-based intervention. Generally, as I said, they are mainly used in prevention. And before you use any evidence-based family intervention, you have to go by the theory or determine what you think might be the etiological factor or the cause of these substances, or what led to substances in the first instance. So there must be a theory to back up what you're doing, and then what the community needs and risk level, how you match them, and the therapy too must be appropriate for the age of the client that one is trying to help, because sometimes you have children, or you have early adolescents or late adolescents, or even young adults who abuse substances. And as the previous speakers pointed out, sometimes may even be a parent. So you have to choose an appropriate family intervention that is evidence-based, and you look at how often you will use this intervention and at what dosage. So all these have to be determined, and usually trainings are done in all the various interventions. One has to undergo this training, to be certified, to use them, to employ them in the treatment of clients who abuse us or use substances. And in doing so, the intervention has to be very interactive, because it's not a didactic way of just giving, maybe talking to people or giving the lectures. And just going, no, but it has to. And when we do that, as I say, we have to look at who is the center actually of focus now. Who is the client in this case, in the family that uses substances? And
Professor Mamdouh. Professor Mamdouh, it looks like we lost connection with you. Attendees, can anyone hear Professor Moses Mamdouh? And you have to be sure that.
No.
Oh, okay.
No, I think we've lost him.
We lost. Okay.
Perhaps as we wait for him to return, Martin, we could take the questions for the other presenters.
Yes, we'll do that straight away. We have a couple of questions. Let me put them out quickly. Okay, we have a question from Professor Michael Ezewa, and he said, I agree that SUD could be a problem of the patient and his or her family. I suspect that the family structure is a strong determinant of the degree of family involvement. A toxic family, I think it's more of a contribution as against a question. Professor Ezewa, let me give you audience because I can see that you indicate that you have a question and that came up. So please confirm if that was your question or you would like to ask the question straight away. Professor Ezewa, can you hear me?
Yes, thank you very much. Yes, you got it correctly. What I tried to say is that the family structure is very important. I mean, the structure and the dynamics, the communication and so on, they are important determinants of the extent of family involvement in SUD. So like I said, if we have a toxic family, the individual members may not be as involved as you have a harmonious family when one of them just became a drug user. So the family structure is very important. It just like say a comment is very important in determining the degree to which SUD becomes a huge burden or otherwise on the family. Thank you.
Okay, thank you very much.
Thank you very much.
Okay, thank you, Professor Ezewa, for clarifying that. I think that is very clear. Are there other questions? Is there anyone who possibly want to speak? We can give you audience. Either you indicate by a raise of hand or you go straight away and speak or ask your question. While we do that, someone please follow up with Professor Mamdouh if we can still at least reconnect or you can still reconnect with us. At the moment, I'm not seeing any other question on the chat box. If you asked question earlier and we've missed it, please go ahead and ask your question. Otherwise, we are not seeing any other
Martin.
Yeah, I was gonna. Okay, go ahead, Beatrice. I was gonna.
Okay,
there's a
go
question.
ahead.
Yeah, there's a question about how do we about codependency. I think it was about how do we break free from codependency and still continue caring for the person. I don't know whether Prof. Rania, do you want to answer that or I should just go ahead while I'm at it?
Please do, Prof.
Yeah, Moreko, please go ahead and speak on it. Then
Okay.
Prof will come and Prof will add to your comment.
Yeah, I think like as Prof. Rania had presented, and when you see the linkages of codependency and the roles that each family member plays, that's where we can actually start from to address the roles and the challenges, the psychological challenges that each person in a role actually has. And I think it also goes hand in hand with what Beatrice actually presented about understanding assessments of each family member, so that you can actually pick out what are some of the things that they are struggling with at an individual level. I don't know whether Dr. Rania, we can still
Yes, that
love
sounds great.
our family members, but understand clear boundaries that are healthy for the person actually to be helped. We need to help ourselves in that first. Dr. Rania, you can go ahead.
Thank you, Professor Morocco. A very important notice that the codependent member is not bad. He's not a bad person, or she is not a bad person. But I guess we all know how far the education and the training for the family will be very beneficial, because we teach them and we engage them into taking care of themselves instead of losing their self-care, being spiritual and losing the control and getting rid of being under control of their children, of the substance use patient. They're not responsible of the results, and the more they take care of themselves, we engage them and train them that the more you take care of yourselves, the more that the substance use patient will take care of himself upon you. And sometimes they go up and sometimes they fail again. Sometimes they are cheerful and sometimes they cannot get into the skill. But within the same 3-4 months of the treatment of the patient, with the same time, the family are coming on weekly basis, and especially the codependent one, and we work on each point. The blurred boundaries. Okay, so he has to say, may I enter before entering your room? He has to knock on the door. He doesn't have to open your closet. He doesn't have to take off your clothes. And when you do this, don't feel guilty. Don't feel that you are not doing your role as a parent. And the more and more we go, the parents or the codependent members start to go deeper in his own childhood, in his own traumas, in his own emotional and sexual life. He will be more exploring himself and going away of the substance use patient to be more close to himself or herself. The more the codependent member do that, the more both the substance use patient and the family member are getting into recovery. So as we discussed every point, we need to train them the skill of every point. How to make healthy boundaries, how to communicate positively, how to begin statements by I, not you. I feel happy when you go home early. But we don't say you always come late. You always come late is a bad communication, but I get worried when you come late. I am very happy that you came early. So by training the communication, the healthy boundaries, the self-care, and the shame, the toxic shame, all of these things are coming by training. And thank you for the question.
Thank you so much, Professor Mamdouh, for adding to that. We have another question here using the chat box, and it's from Dr. Grace Saint. And Grace is asking, I think this question should be for Professor Kokonya. A situation where the treatment center is far within the reach of the people, can a private or family member carry out the test, that is drug test now? In other words, is it compulsory that it must be done in a qualified treatment center in terms of screening and drug testing? Please, we take that quickly as we begin to wrap up, because we have actually spent far more than we anticipated for this webinar. Incidentally, we are not sure that Professor Moses Saudo will still be able to reconnect with us. Thank you. Professor Kokonya, please go ahead.
Yeah, That is a question asked with a sense of reality for many people who are not accessible to quality services. However, a relative getting involved in this will create conflict of interest. And as I said at the beginning, this work is restricted to people who are competent. And what I mean by competent is they are trained people and they work in an accredited laboratory. My advice would be that they look at the nearest facility which can help them to reach an accredited laboratory, but as a family, they should not test themselves. Thank you.
Martin? Martin? Dr. Martin? Did we lose you or you're muted?
Sorry, I actually muted myself and I didn't know that I muted. So thank you, Professor Kumpuya, for that clarification. It is obvious that we have lost connection with Professor Audu, and he's not likely to be able to reconnect with us. I think I understand there are very few slides left, and Dr. Beatrice Kathungu would like to take the few slides so that we don't leave it hanging. Please still bear with us, and I want to assure you that when next we are planning for a webinar with a high level of impact like this, we definitely will have to accommodate, and make sure that we have a fewer speakers at the same time, especially considering their wealth of experience, and we don't want to lose that in the course of being in a hurry or so. Thank you for your understanding. Beatrice, over to you, please.
Thank you, Martin. I think you can. Yes, thank you. So these are some of the ideas that Dr. Moses had for us, that some of the interventions we can have with families include what is called the multi-systemic therapy, which is anchored on the socio-ecological theory and the family systems theory, and basically targets to address issues with juvenile offenders who may have drug use problems. You can go to the next slide, Martin. And it's actually individualized, but at the same time, it has a lot of intervention strategies that could target the family. For example, we have what we call the structural and strategic family therapies. I think I already did say something in the assessment about the structural approaches, where we look at how do we address things like family roles that have been distorted, family hierarchies, boundaries, how do we restore them, and so on and so forth. Strategic family therapy is about communication strategies, and we want to look at how does the family interact. Are there dysfunctional patterns that need to be addressed so that the family can adopt more functional ways of interacting, whether it's the way they communicate, etc. We have parent management training, really important. Sometimes we say that there is no parent that ever was given a manual to parent the child when they got them. So some of the strategies they are using that have ended up being dysfunctional is the best they know how. So by giving them some training on parental management through this MST, then you're actually helping the families using behavioral therapy techniques. And I think we do understand behavioral therapy is about learning and learned behavior and how to bring changes. Then we have cognitive behavior therapy techniques, issues about thought patterns that are dysfunctional, issues about automatic thought processes that need to be rewired so that clients and families can function well. Now, some of the guiding principles of treatment, including finding the best methods, having what we call, and really staying positive and strength focused. I think this is so important because, and you remember in one of the slides where I was talking about why we assess, one of the reasons is to identify family strengths. We are not only looking for the problems, but also the strength. We want the family to take more responsibility. We want parents to focus more on the current situations and how they can make changes, much more than thinking about the past, and also looking at the sequences of events and how different strategies lead to certain outcomes and how that can be adjusted to produce different results. You can go to the next slide, Martin. Next slide, please, Martin. All right, yes. It also focuses on what is appropriate for the developmental stage of the members and the family. Of course, there is continuous effort as opposed to a one-time intervention. There is evaluation and accountability and generalization to other areas of functioning beyond just the SUD. Next slide. Yes, what are some of the research findings and the evidence for this therapy? Is that it actually does increase supportiveness in the family, and there is reduced conflict. There are more positive parenting outcomes. There is better cohesion in the family, and there was less depression and psychopathology in the family. So it is an evidence-based approach. Now, why is family intervention necessary? I mean, remember earlier on, we asked ourselves why family assessment was necessary. Why is the intervention necessary? Because we know that family is a primary agent of socialization. We know that it's an element of what we call the micro level influences that will now interact with the other bigger level factors, or what we're calling the macro factors, and that can contribute to SUD. And we also know that family can serve as a beautiful support system, as a beautiful recovery capital for our client. And therefore, by intervening with the family, we shall be reducing the risk of SUD, we shall be addressing factors that may have caused SUD, and we shall also be building what we are calling positive recovery capital for the family. Thank you very much. Over to you, Martin.
Thank you, Beatrice, for the great job. At least you fit in perfectly, as if you prepared ahead that in case it comes up, you'll be able to step in. You did that as if it was your own slide or your presentation. Great job. Thank you so much. I'm sure at this moment there are no questions from what we can see on the chat box. Hopefully, we'll just proceed to the closing part of the webinar. So Beatrice, I think I will hand over to you. But before then, let me appreciate everyone for your patience and for also giving me this task. At least it's a privilege, I must say, to moderate this session, even though at a very short notice. But all the same, your cooperation has also helped me, at least in navigating this session. So thank you for the opportunity. I think it was a great learning opportunity, and so much has been taken away by me personally. I've learned so much from it. I want to believe it's the same for all the attendees. Speakers, once again, thank you so much for the opportunity. Beatrice, over to you, please.
Thank you very much, Martin, for the wonderful moderation despite the challenges. Thank you, members, for your resilience. Thank you, presenters, for the awesome presentation, insights, and discussion. We do not take them for granted. Members, I want to thank you. We are still at 42 for your patience and your resilience. I just want to emphasize that this webinar was arranged as part of the recognition that WHO recognizes this month as the World Mental Health Awareness Month. And it would have been unfair if this month was going to end before we as ICUDDR Africa put our voice across and say that we recognize that mental health is an agenda we must pursue, and particularly as it touches on SUD, which is our core business. We did approach one of our regions, that is North Africa, and we requested them to steer this process of spearheading this arrangement of this webinar. So I wish to thank North Africa, led by Dr. Rania. And today we are being taught how to pronounce her name. I hope I got it right. And so thank you, Dr. Rania, for the stewardship of the Northern region in getting this webinar arranged in such a short notice. I love the way we work in Africa. We dream things and we make them happen. It doesn't matter how much time we have. So thank you, Dr. Rania, and your team for that. We did agree that the Northern region is going to begin, but we don't want people to work alone. We want collaboration. And so we did say that we wanted the Northern region to coordinate, but to also bring in the East, the West, the South. So we had Dr. Kokonya from the Eastern region. We had Dr. Moses from the Western region. We had Dr. Morekwe from the Southern region. And we had Dr. Rania from the Northern region. And so the entire Africa was in this webinar. And all the participants came from all the regions. What a beautiful moment of collaboration, of synergy, of learning from each other. That is what Africa is about. And I'm extremely proud of every one of you for taking up your responsibilities with so much seriousness and passion, as always, to make things happen. Thank you, Dr. Rania, for being the spearheader of this process. We appreciate you. Going forward, we are actually going to have another region coming next year. When we have the next Mental Health Awareness Month, we're going to have the next region. And I can see it's going to be Southern region, because the other day, one of the members in the group asked why she wasn't asked to present. And I said, don't worry, we are coming soon. And so I believe Southern region will be the next one. And next we shall have the Western region. And after that, we shall have the East African region. That's part of our way forward with these annual webinars. The other important thing is that we have rolled out a call for 2 trainings. One of them is the 10-day walkthrough. Kali here set up a link for us to register, and we have posted it in the group. Kindly register. We also are going to have the implementation course training. Again, she has put up another link, and we rolled it up in the group WhatsApp. Kindly register so that we can know how many of us are interested in these trainings, and the ICUDDR office can support us in implementing them. We also are interested in having more of this kind of peer capacity building. And so when the regional leaders meet, this time they were the ones that were presenting. It was deliberate so that they set up the pace. And from here, we're actually going to be having our quarterly webinars back, and they will come to you. And when we have a Western region webinar, we will ask now the Western team to get us people from the different countries. And so we are going to be hearing from you. We're going to be learning from you, because we know every one of us has so much knowledge that they can share with us. And so please listen to the WhatsApp group. A lot is coming, and we shall be calling on you to be a part of the webinars. Finally, I want to thank, as always, Kali Sasi. She is so helpful to us. She came through so quickly. I tell you, when we told her we wanted to do this, very quickly, I think less than 2 weeks, she was on board and she's made it happen. Thank you so much, Kelly, as always. You are Africa. We shall give you an African name. And you will have 4 of them from each region. And we do look forward to seeing you in Africa one of these days. For those of us who have the privilege of being able to attend the ICUDDR International Conference, we wish you all the best. Please represent us ably. And when you go, we will feel like we have all gone. And we know that next time another team will go, and we shall keep doing that and growing the capacity of every one of us. I will ask Kali to just say something as a parting shot before we close. Thank you. And thank you, Martin, for the great moderation.
Beatrice, you are too kind. It is my pleasure to be here and support the important work that you're doing and the important work of everyone who's on this call today. Thank you so much. I do look forward to seeing some of you in Thessaloniki, Greece. And yes, Beatrice, hopefully one day in Africa. This would be wonderful. So thank you very much, everyone. I know this is very late in your evening and you stayed online to be a part of this work. Thank you.
Thank you very much. And I want you to turn on your video and to turn on your audio and say goodbye in your language.
Boroko.
Look forward to see you soon. Thank you.
Boroko.
Bye.
Boroko.
Bye. Kwaheri.
Kachifo. Kachifo.
Okay.
All right.